Whoa. Tension for days. Whoa. Damn, dude. It's like Ryan Bull. Come on up, buddy. Hi, I'm Dr. Chris Stepien. I am the clinic director of Barefoot Rehab in Denville, New Jersey. It's about 45 minutes from Newark Airport. And I'm also one of the co-founders of Adhesion Release Methods. And I'm here with the wonderful Dave Tate, and we're gonna talk about his shoulder and the chronic shoulder pain that he's been dealing with for about 24 years or so, right? 24 years? Okay. How old are you now?
58.
58, okay. So what we typically do when I take on a new patient is we take a history, and the purpose of the history or the consult is to get all the data we need for the shoulder, any of the other issues around that area. And the point is to determine first, is this a musculoskeletal problem? And what is our diagnostic hypothesis around what tissue is pissed off? So a lot of times people can have a lot of different things going on, but there's often at least one, there could be two or three, but it's not everything, the pain generator. The pain generator is the tissue that's basically screaming out and say, hey, I'm toast, I'm done. With the idea being that with treatment, any treatment should be for the purpose of reducing load on that tissue. And if you reduce load on that tissue immediately during that treatment visit, but also long-term, 1 week later, 1 month later, and the symptoms are better, 20%, 30% better, there's less load, or the tissue has increased capacity to be able to handle the load that is going on. So that's what we're gonna do now. Make sense?
Yeah.
Okay, so 58-year-old male, with your shoulder, where are your primary symptoms? And we'll start with one spot, and then we can talk about other spots too.
I would say deep in the joint capsule.
Front, back?
Right, boom, middle, like
Okay.
straight in.
So you feel it in the middle. You feel it deep in the joint. You can't say if it's front or back.
No, it's just all inside there. So I can't say it's like rear delt, side delt, front delt, trap, or anything like that. It's all
Got it.
inner.
Okay, so yeah, that's consistent with the severe glenohumeral joint degeneration that you have in there with the cartilage, so that makes sense. When you feel it, what does it feel like, sensation-wise?
Typically 24/7, it's a dull ache. Like if it wakes me up in the middle of the night, obviously it's going up from that dull ache, and it's just changing position. I'm used to that. Let's just put it that way. That's always there. Now, if I go outside of what the range of motion is that I have, then it becomes the pain, right? And that can be right there. It starts, that's my external rotation. That's my internal. So anytime I go past any of that, reaching into my back pocket, anything like that. And then if I'm working for an extended period of time, desk or whatever it's gonna be, it will start in there and start to dig into the trap there. And then that's kind of my sign where I need to either, get a lacrosse ball, dig into my subscap, dig into my trap, do anything to be able to stop that, because once it starts working up through the trap, then it goes up, then it lights up my neck and the whole side of my head.
Where in your neck?
Right there, deep in the trap.
Is that the only spot in the neck that it bothers you?
Yes.
It doesn't go into the back of the neck, it doesn't go?
No, it's just like, bam, right there.
And then you did say, did you point to your eye?
It will go up. If it's like starts there, right? And then it will start to move up if I don't release it in some way.
This way?
This up around. Like
lesser
that.
Lesser occipital nerve. Beautiful.
If it gets into my neck, I'm kind of fucked. Right, because once it gets there, then it's going to be a few hours. If I can catch it when it's in that one spot, and sometimes this may happen if I'm training and I'm benching, or something like that. It will, not all the time. I don't know what the trigger is for. I know the trigger if I'm working here and it's just statically kind of contracted that whole time in this position. I know that trigger, but if I'm training and it starts, then it's a little bit easier for me to control that, because then I just find some piece of equipment and ram my subscap into like a J cup and just start doing release patterns to where if with any of those, even if it's a lacrosse ball and I'm laying on my back and I find the hot spots throughout the subscap, neck, or trap, and then I'll start with a bench pattern, which will usually stop right about there. Then I'll pull it through. Then I'll work into seething the sword. Just the PNF patterns, and usually that will, almost 100% of the time, that will release that there. Now, this may not even be related to the shoulder. As you were saying earlier, it could be multiple things, but that's what I deal with from that outside of the range of motion and, not being able to squat and all the other stuff.
But when you're typing, you feel your shoulder start to bother you first, then sequentially, that's when the neck starts soon after.
Yeah, a little bit, yeah.
Okay.
Yeah.
And you said when you're typing,
I don't know if it's the typing, it's just this position.
And being in this position,
because it can be a mouse, you know what I'm saying?
Just moving the arm out a little bit in front of you. Have you noticed if you're able to keep your elbows more at your sides with the keyboard closer to you, does that change anything?
No.
Okay.
No.
So in other words, if your elbows are down by your sides.
Well, actually, yeah. If I lower the desk.
Yes.
Yes. If the desk is higher, because I got an adjustable desk, the desk is higher, it's not good.
Okay.
I mean, that immediately, if the desk is too high, is immediately problematic.
Got it. Now, you said the symptoms are constant and deep ache. How low do they ever go in the past month on a daily basis? Is it like if 0 is no pain at all, 10's the worst pain in the entire world, how low do your symptoms get to?
3, 4, which to me is like a 0 anymore.
Yeah. Because
I have to compare it to this, right? So I compare it to the other one. Like, what's this feel like to this one? So there's that difference.
Got it. And how high can your symptoms get in the past month?
It's never like a 10. The only time it's a 10 is if I find myself in a position to where it doesn't happen. But if I'm being handcuffed, if somebody's arm barring the thing, and for me, that arm bar is going to be a way lower range of motion than anybody else with an arm bar.
Yeah.
But anytime I'm caught in a position there, but it doesn't last long because the reaction is quick.
Got it. How many times a night do you wake up typically on average?
Well, once to piss, but that's a separate issue.
Right.
From the shoulder anymore, it's really rare. Since I've lost weight, it's rare. When I was heavier, anything over 250, 260, it would be once or twice.
What do you think that was about, that the weight being lost causes you to wake up less with the shoulder?
I can only speculate and think because there's less girth pulling down, because I do sleep on my back. The CPAP kind of forces me to be able to do that. So I'm not on my side, I'm not moving positions, that there's just less weight pulling down, or my neck position could be different on the pillow because there's not as much neck girth as there was before.
Got it. Would you bring your arm just up like this, 0 to 10, what happens to the pain?
It's like a 6. And that one's right there. So it's not deep, so it's there.
Got it. If you start to go behind your back, how intense?
That's the deep in there.
6 out of 10 still?
Yeah.
Training wise, are there any movements specifically that make the symptoms worse?
The ones I don't do, overhead press, for instance.
Yeah, obviously.
I can't do that. I can't put a squat bar on my back.
Right, you told me that.
Yeah, so I can't do that. So, but those are all going in those ranges that I've lost access to.
Right.
A cambered bar bench, so a bench going lower than my chest. Dumbbells.
So where are your hands with the cambered bar on the bench?
Well, they would be here. I'm okay. Actually, I'm better with a reverse grip with any of the American bars that we have. I got a zillion cambered bars. But if it's here, it's way better than if it's here. This doesn't really make that much difference to this.
Got it. Okay. First thing in the morning when you get out of bed, how are your symptoms relative to how they would be an hour, 2 hours later? Are they a little worse or stiffer?
The same. I can't say it's worse when I wake up.
That's interesting. Because typically, when people have increased symptoms when they first get up, it's usually aligned with the joint, the degeneration being stiffer, more provocative, or in pain. So what happens a lot of times, especially when people are, I would say middle-aged, but mid-30s, 40s, 50s, they'll feel a little bit of stiffness or pain in the morning, but it'll be a relative non-issue for them. They'll be able to go through their day. They'll be able to work out, especially they warm up the tissue, they move the joint. And what they don't necessarily realize is that that is the joint starting to scream out just a little bit over time. And I usually tell people, like, look, if you can get those morning symptoms to not be there, what it's indicating is that you're putting less load on the joint, so that long-term, 30 years, 40 years down the road, your joint's gonna be a lot happier than it would be if you just ignored those morning symptoms and just work through things. So whether it's a training program, whether it's treatment or something else, if we could minimize those morning symptoms, it's indicative of creating more longevity for the joint. So in some way, it's good that it's not necessarily worse for you first thing in the morning.
It used to, I mean, not so much the shoulder, but everything used to be that way when I was heavier, right? So waking up in the morning when I was heavier was a fucking nightmare. You know, that was just everything I could do to get into the hottest shower I could. And that was hips, back, fucking everything. It just hurt. So the weight loss, it helped with that as well. I didn't expect it would, but it did. You know why? I don't know. I'm just thinking
there could be less
better circulation. I don't know.
Less inflammatory molecules from having less fat, which is
less food, you know, so
less food too. Yeah, big time. Okay. Great. Okay. So you said so the primary spot is there. The next spot is the anterior trap behind the clavicle spot. And you said that this neck symptom, if you would come, first you feel the shoulder symptom, then you feel that symptom. But you said typing or certain types of training will cause that neck symptom specifically to come out. Correct?
Well, if it's a training, it's going to go directly into that here. It's not even here. It's just like, it's like whack.
Training would cause the neck and not necessarily the shoulder.
Yes. It's, but it's, like I said, it's easier to direct it away from it.
Yeah. By how you change your technique, or if you do some of the self-myofascial.
The self-myofascial. Yeah, because normally I don't have to pull out of the movement.
Got it. Okay, got it. Is there any other provocative motion, posture, or activity that would cause this to come out?
No.
Okay.
If there is, I have to think real hard about it, which is kind of like not.
What about if you're texting or you're reading or something like that with your head down?
No. Normally I don't do that anyhow.
Got it. You don't read?
I do, but everything's up.
Smart.
Like if it's a Kindle, it's here, and I got this little clicker thing.
Got it. And then, does it go from here up this way, to this end? It goes behind.
Yeah.
So does it come like this from here?
Up. So it will go here, kind of like up through the back of the neck there, into the skull, and then.
Got it.
If it goes around, then it's like in my eye, and at that point, it's going to be a fucking migraine.
Got it.
I'm not going to let it go there.
Got it. And then you said if it's fucked for a few hours, is it typically a few hours? It's not like a day.
If it goes into a migraine, it's going to be a few hours.
Okay, got it. And then to stop that, the myofascial work, is there anything else postural related or like laying down?
If I can pull, if I can distract it. It doesn't work as well, but it's the backup.
Distracting primarily with your neck, or you're anchoring your shoulder?
Really anchoring the shoulder first here, and then I kind of feel where it is, like that's too much in the front delt. So then I'll get there, and then I can start turning that way, and it will get back where I want it.
Got it. So it sounds like the nerve tract. One of the things primarily with our methodology is primarily specializing on adhesions, but 80% of the time those adhesions are around peripheral nerves. So with shoulder symptoms, the biggest area by far that we get into is subscap and the neurovascular sleeve. And then there are like 5 or 6 other nerves in there that we'd be checking. And then there it looks like you're tractioning just the nerve tract from there, coming through the thoracic outlet and then going up to the nerve roots. So we'll check that as well and see how that's being affected. And when people go like this is typically the lesser occipital nerve, which comes right out from this area. So we'll see if that is stuck too. Okay. And you haven't had any cervical MRIs?
Yes and no. What was the last one? I had a CT.
Okay. CT scan.
Yes, because of the AFib, heart and stuff like that. So they're reporting, degeneration through pretty much every disc in my back. So it's not primarily the imaging of that. I do have imaging of that going back to that time there as well, to where, they're all fucked up, but there's not symptomatic.
Got it.
As long as I keep my torso, my core, erectors and all that. Actually, as long as I keep squatting, I have no problems. If I take the squatting out, then it starts to become problematic.
What do you think it is about the squatting that helps the neck?
I don't think it's, now we're speaking spine.
Oh, spine. Okay.
Right, it's just the bracing.
The bracing.
Yeah, just the reinforcing of that bracing.
Got it.
Or, placebo, I don't fucking know. But if I go 3 weeks without any type of squatting at all, lower back will start to have a little bit of symptoms. If I throw that in there, even if my lower back is jacked up, I don't suggest this to anybody, but if I throw this, then it immediately will go away.
That's awesome. Awesome. Okay. Have you ever had an episode in your neck where you could like hardly move it and it was stuck for a day or a few days?
Not a day, but definitely for a long enough period of time to where I have to lay in bed, just kind of support it. And
one time you think, or multiple episodes?
Multiple, but it's been a while. With the weight loss again is kind of helping negate a lot of all that.
Got it. And you think that your shoulder symptoms started around 2002?
Ooh, no.
Before
2000, a couple years before the symptoms started, because I put off the surgery as long as I possibly could. And then
which
the first one, when they went in the first time, it was the bone spurs and a torn supraspinatus, I believe.
Yeah.
And so that one got to the point to where it felt like there was a knife in my trap 24/7, and it just would not stop ever. And there was no other choice but the surgery, because it wasn't, with a lot of pain, you just kind of get used to the pain.
Yeah.
So if it's like a 6, you get used to the 6, and the 6 becomes your new 0. That wasn't the case. It was just fucking always there, and I couldn't do shit. After that surgery, I rushed coming back, competed like 12 weeks later. It was cool at the time, but it led to the second one, basically going in and having to remove the spurs again.
When were these two?
That would have been the 2002. So the symptoms probably would have started 2000. And I think a lot of those symptoms, when I dial it back, I've dealt with pec tears since high school. So the main shoulders, because this pec tear had to be, the tendon came off, they had to reattach that one. This one was just muscle, tendon stayed attached, so we left it. This one happened probably 6 months. As soon as I came back from this one, within 4 to 6 months after that, the shoulder started. And I think this is gone. This has to compensate.
Yeah.
And then it's being overloaded, and then it goes into there.
Got it. Okay. Pec tears, how many?
Well, it depends how you want to define a pec tear, right?
Yeah. Did it never completely?
This one did.
Okay.
Right. When this one tore, it was, man, this is going way back. So this would have been like 90. When this one tore, it It was an interesting one because the whole pec was under the nipple. I did it in a bench meet, and it was one of the first meets after I got the West Side Barbell. And I was telling Louie, like, something's fucked up. Like, the bar crashed on me and all this other kind of stuff. Nothing else got hurt, but it never bruised. Ever. So when I went back to college, I'm having it looked at, and they're like, well, you just tore a muscle. And I'm like, what the fuck? When I flex this, there's nothing, it's all under my nipple. Like, what the fuck are you talking about? And it took 6 weeks until I had somebody that really, and we're going back to a time to where pec tears were, I think I was the second one to have a pec reattachment in Columbus. And then he told me at the time it was just the tendon. Tendons really don't bleed. So they anchored that back in there. There still is a divot. This one here, maybe whatever date I told you, like the 2000 or whatever it was. This one, bench just shifted, a bench shirt took me this way, boom, and the muscle just, pec major, essentially just, it's cut in half. You'll be able to feel it. I mean, it's gone, but the pec minor is still there. But outside of those two, what other people would call a pec tear, which I just framed as I'm tearing scar tissue, hundreds of times. You know, especially in this one when it was coming back, because at first you're like, oh shit, I tore it again. No, I didn't. Then this one here didn't have a lot of that, maybe once or twice, but by the time this one happened, I already figured out how to keep this from doing that.
Got it.
You know, which was the opposite of everything everybody else told me to do. You know, everybody else told me to strengthen the end position, do pec work and all this other stuff. Then when I stopped doing all that and just started focusing more on tucking harder, putting more load on my triceps, staying away from it, it all went away.
Got it. Okay. Anything else you think that I should know with the shoulders and the neck? Okay.
No.
Do you have any questions for me at this point?
No.
Okay, cool. So from a diagnostic hypothesis, my primary job is to figure out tissues and pathologies. It's sounding like it's the glenohumeral joint cartilage degeneration with probable labrum. So as far as that's not necessarily the supraspinatus tendinosis or the tear that's being involved with the way that the symptoms are presenting. So that's the pain generator. And it sounds like this is most likely nerve roots coming from inside the neck, and then all the nerves connect, so coming up to the lesser occipital nerve in there. So what we're gonna do with the exam is we're gonna do 5 neck tests, 3 thoracic tests, 1 shoulder test, a little bit of shoulder range of motion, and the goal, we have numbers and standards where I have to hit. Just a lot of different trainers, coaches, and different types of pain doctors, therapists have ranges. So we use those ranges to determine where you're at relative to where everyone else is. And that gives us a relatively good indicator of where something is wrong, whether that's joint degeneration or whether that's adhesion. And then if there's adhesion, the idea is that if we can remove adhesion and it's relevant to that restricted range of motion or provocative movement, then it's gonna make the test immediately better. So we're gonna feel a bunch of tissues. We're gonna go down a list. We'll talk a little bit about what's going on and what we found. I'll let you know what I think my expectations are, and then we're gonna try treating some stuff right away and see if we can make a difference. Like I mentioned to you a couple times, I don't have any expectations right now. Typically when we take on or accept a new patient, about 50% of the time I expect to get some type of relief at the very first treatment that's lasting, not just 24, 48 hours, but lasts 3 days, 7 days, a couple weeks. 80% of the time I expect that within 5 treatments, maybe another 85% of the time by visit 10 to 15, if the patient can trust me enough to let me keep going with that. And then there are 10 to 15% of people who I take on, their degeneration so bad, they have other metabolic problems, their stress is so bad that I can't necessarily help them. And so just for context, if we're getting about 4 new patients per week, in the past 3 months, I can think of 3 people who I've sent to the surgeon. We either cleared out some adhesion, the tissue's cleaning up, and just the structure is so bad and their symptoms are so bad they can't tolerate it. I'm like, okay, you need surgery. Or other people, we'll talk about this on the podcast, but hypertonic trigger point knotty muscles are not adhesions. So when that's just staying all glued up and stuck despite me clearing out adhesion or nerves in other areas, then that's just also an indicator that the joint is what's causing those muscles to be so protective and why we're not necessarily getting relief. So what's cool about this adhesion stuff is it helps a lot of people who we only take on patients who have been to at least 3 other doctors or therapists. So any of my success or any of our providers' success who does this methodology is helping those people in chronic pain. So there's always hope, but we're not magicians. We can only fix adhesion when there's adhesion there and it's relevant. So we're gonna see what we can do today.
All right, cool. Cool.
Awesome. So you're gonna put these glasses on. It just gives me a flat line so I can put the level. The app is on here. So you're gonna put this on. When we do these tests, you're gonna tell me exactly what you feel. Even if you're feeling pulling or stretching somewhere, I wanna know, because that's symptom data and it tells me that some tissue is speaking up.
Yeah.
So even if you feel stretching or pulling, I wanna know.
So where do you want my lower back against the wall? Do you want anterior, or do you want flat, or just?
Just against the wall is fine.
Yeah.
So I'm gonna just put this block behind your head. Oh, I apologize. First, take a step forward for me and look straight forward. You're okay. So we're just getting a neutral measuring. 2. From here, you're gonna slide the back of your head up the block and tuck your chin in, and just hold that for me for a second. 4 degrees, 16% function. What do you feel?
Traps, like
Both
upper
sides?
traps. Yes, both sides, neck. Yeah.
Bilateral upper trap area,
And
0 to
between
10.
the shoulder blades.
0 to 10 here.
3.
Pulling
Um,
or ache?
ache. Then the shoulder blades. Actually, it's probably a little bit higher. So let's say that's a 4.
Okay. And between your shoulder blades down in this area, your bilateral medial scapula, 0 to 10.
4.
4 out of 10. Okay, good. Let me take this block away. We're done with that. Cervical flexion. Tuck in and come forward. Yep. Good. Stay there for me. 33 degrees, 55% function. What do you feel?
Traps out towards the rear delts. Say that's
This way?
Yeah.
On both sides.
Yes.
Bilateral LS area to posterior superior glenohumeral joint, 0 to 10.
3, and then right through here, probably 2.
2 out of 10 bilateral anterior medial T2 area. You said 2? Okay.
And it's also aching.
Yeah.
Aching. Okay. So stay here for me. And then you're gonna tip forward even more from here. Come a little bit more. Good. CT flexion. 52 degrees, 57% function. What do you feel?
Lower trap, very lower trap, yeah. And that's probably a 5.
Bilateral T8 area, 5 out of 10. Pulling or aching?
Aching.
Aching. Good. Okay, you can bring your head up. Now we're gonna rotate. Hold your horses. There we go. Slowly turn your head to the right. Good, stop there. 41 degrees, 45% function. What do you feel?
Top trap, right side, 6.
6 out of 10 right LS area. Pulling or pain?
Pain.
Like an ache?
Yeah.
Okay, aching. Good. Look straight forward for me. Slowly turn left. 43 degrees, 47%. What do you feel?
Same side, that right side. Nothing on the left side. That right side, but it'd be like a 3.
3 out of 10 right LS aching.
Yeah.
Turn your head to the right again.
That's like same that area there, but now 6.
Okay, so what's interesting, Dave, stand here, face that way. Just for Nate. Turn your head to the left. So his head is laterally flexing this way, which suggests that he's avoiding putting load on this lower cervical spine. When he turns to the right, he wasn't doing that as much. Do you feel that, Dave? Do you know?
Yeah, I also feel it won't go as far.
Uh-huh. Yeah, that makes sense. Okay, cool.
And if I force, I mean, I can force it, but then it's
Yeah.
it goes way up.
I get it. Done with the wall. Let's go back over to the table. Come and stand over here for me. Just watch me first. In plane, so if this is in plane, not forward, but in plane, we're gonna bring our arms out the side overhead as close to your ears as you can go. Go ahead and face this direction for me. Go ahead and bring your arms out the side and overhead. Okay, so right side, he's getting to 90 degrees and severe load across his neck, his LS area. What do you feel with this?
Tightness, right? And then there was some crepitus before I got here.
Okay.
You know, so like right, boom, boom, right there. It will pop.
Here?
Let me think
or is
about
it deep in the joint?
It's more deep in the joint.
Okay, 0 to 10, that tightness.
Oh, that's like a 9.
9 out of 10.
Yeah.
Okay, good. You can go ahead and bring your arms down. Now I'm just gonna do it. Okay, passive shoulder abduction. 120 degrees. What do you feel?
It's less than what the tension was when I was doing it.
50% less?
Yeah, probably.
Okay. External rotation at 90, Kate. 50 degrees. Internal rotation, yuck. 0.
Tightness in the same area, the lower trap.
This area?
Yeah. Yep.
Just holding this position?
Yep.
Good, come on up, Dave. Right C2 nerve root and middle scalene. Moderate to severe.
You've had this shoulder pain since a little before 2000-ish or before, and your MRI from 2004 said severe degeneration in the glenohumeral joint, the AC joint, diffuse labrum degeneration, supraspinatus degeneration and tear. You got neck degeneration, you got thoracic spine degeneration, and you just put your body through a lot, like a lot of us athletes. But the good news is today we found a bunch of adhesions and nerve entrapments in your body that my expectation today, we made some changes in your ranges of motion and your tests. And my hope is that you're going to feel some type of capacity or symptom change where maybe you can sit for an extra hour before those symptoms start coming up your neck, or you can put a little bit more load on your shoulder joint before it starts getting pissed off. And then in the future, if you end up wanting to get more adhesions removed, you at least know that there's hope and there's possibility of further pushing off this potential shoulder replacement.
So I'm going to show you how Dr. Ryan showed us how to do canister, and I want to see what happens with your canister and with potentially loading into some scap retraction, because it looks like if I can get you to be more here, it's going to put way less load on your neck. So we need the face parallel with the ceiling or the ground. From here, you're going to tuck your wing bones underneath you. So it's bringing your scapula down your back. Then you're going to breathe in through your nose and out through a pencil in your mouth. And that engages the diaphragm, which you know better than I do. Then you're pushing your TL area down into the table. And I'm gonna keep breathing like that, keeping all of this engaged. Now I'm in a neutral spine. So then I just squeeze my glutes a little bit and I do a Kegel, so I contract my lower pelvic floor, and I keep breathing like this. So this is a brace, supine. You may even have done something like this before. So first I'm gonna see if you can do this, but second, if you're able to do this somewhat comfortably, I wanna see what happens if we get some type of band around your wrists, and we're gonna do some external rotations, because I think that this may offer value to you as part of your prehab rehab. Finger straight. You can relax the hand just like this. Bring your elbows forward a little bit more forward. Good. This way. Good. And now with that whole canister position, keeping everything tight, go ahead and externally rotate very slowly. So bring these out this way. Yep. Good. And come back. Very slow. Keeping the neutral spine, keeping your glutes. Nice and slow. Good. And come on back. And again. Any symptoms?
No.
That's awesome. That's awesome. Good. Awesome, Dave. Come on up.